Okay, next talk will be on platelet-rich plasma decreases incidence of hernia recurrence using Stratticetm mesh in a rodent model of chronic ventral hernia repair, which will be presented by Jeffrey Van Epps. Oh, you're right here.
Thank you very much to SAGES and to our distinguished moderators for allowing me to talk this morning. I'm excited to tell you about a project I recently completed looking at how we can improve chronic ventral hernia repair using a rat model. So luckily with this group, I don't need to talk about the weight of the clinical problem. We still perform over 350,000 ventral hernia repairs annually, but we're not quite there yet. The hernia recurrence rate in short and long-term data demonstrates that out to 5 to 10 years, up to a third of our patients are getting hernia recurrence. But it's not just hernia recurrence, it's actually the superficial and deep infections which actually plague our implants as well. And there's a lot of data to support that improving early metrics of wound healing can avoid a lot of these complications. But this suggests that we need to fix how hernias are repaired at the cellular level, which usually connotes having to use things such as synthetic growth factors, which are very expensive. This is just a reminder of the complex interplay that's required for soft tissue repair and all of the growth factors required. Now, usually platelets are thought to only participate early on in the platelet clot formation, but they actually contribute a lot to these growth factors. Our lab previously characterized platelet-rich plasma, which I'll from here on out be referring to as PRP, and it shows that it has a very unique host of growth factors that are perfect for soft tissue repair. Further, it's sufficient to cause the migration and proliferation of mesenchymal stromal cells in vitro. Now, PRP is not new. It's been in use since the 1980s, but mostly by other surgical subspecialties. And when platelets are activated and release their alpha granules, these growth factors they prime the milieu of the local environment for regeneration. But it's largely been overlooked for the purposes of this project. So our hypothesis was this, that if you use and add autologous PRP to ventral hernia repair, that we can improve these classic metrics of wound healing and possibly the overall quality of our repair. So briefly, Lewis rats were used for this operation, and chronic ventral hernias were created by incising the full thickness of the abdominal wall at the linea alba for 2 centimeters. We close the skin over it, and we wait at least 30 days to allow a chronic hernia to form. We come back, excise the hernia sac, define our hernia borders, which as you can see is 2 centimeters here. And then we have 2 groups that receive either a control group, which receives our mesh alone, placed in intraperitoneal underlay bridging fashion, or in our experimental group, they receive the mesh soaked in autologous PRP, and then the skin is closed. We have different time points. Our first time point was 3 months, and this is a representative samples of what we saw at necropsy. And you can see on the right, our control group compared to our left, our experimental group. Even at the gross level, you can see differences in neovascularization of our mesh and differences in peritoneal adhesion formation, which I'll talk about in a moment. But to begin with neovascularization, our control on the right, you can see the mesh muscle interface here. As compared to our experimental group, we saw a striking difference in the amount of neovascularization present. Zoomed in, you can see that the experimental group had much more robust neovascularization, even down into the thickness of the mesh. Further, we saw a greatly increased immune cell infiltration of our control group with some granuloma formation and greater mesh degradation. This was backed by molecular evidence, as you can see, upregulation of classic angiogenic genes as well as collagen 1 and 3, consistent with tissue deposition, as well as genes specific for myofibroblasts. So we're not just scarring, but we're actually calling in the cells to heal more close to the native tissue. At 6 months, which is our long time point, we saw a striking difference between the two. You can see our control group, we had a lot of mesh failure and hernia recurrence at the center of the mesh. We saw 9 out of 12 rats, or 75% mesh failure. We saw 0% hernia recurrence in our experimental group with PRP. To add objective criteria to this, we used a digital caliper to assess mesh thickness at necropsy and saw a striking, very statistically significant difference between our 2 groups, with our PRP group in red here. Further, we wanted to assess differences in peritoneal adhesion formation, so we used a modified Hopkins adhesion scoring system, looking at frequency, size, density of adhesions, and then the dissection required. Here's an example of a 0, no adhesions. Here's an example of 1, which is a single band, which is easily easily lysed. And then there's a score of 2, which has 2 adhesions, but you can still use blunt dissection alone. 3, it's much thicker. You have to use sharp dissection, but you can usually avoid serosal damage or organ injury. And then 4, where you have matted peritoneal adhesions. And we saw, again, a statistically significant difference between our 2 groups. So in summary, I think I've given you some evidence to show that autologous PRP can improve the classic metrics of wound healing, as listed here, and that by doing so, we can improve the overall quality of our ventral hernia repair as assessed by hernia recurrence and peritoneal adhesion formation. Now, future directions, I think it would be warranted to see how PRP can be applied to other aspects of how we use acellular dermal matrices, as they're currently kind of relegated to occasional bridging repair or to breast surgery. And other animate models, and further research is mandated. I'd like to thank everyone in our lab and my clinical mentors, Dr. Barbara Bass, Dr. Bradley Weiner, Warren Ellsworth, Enya Tashioti, and of course, Dr. Brian Duncan. Thank you very much.
Great job. Open for discussion.
Superb presentation. Thank you for presenting that. I find this data fairly interesting, and one thing I wanted to ask you is to translate this into present-day clinical practice. And it really comes down to a simple question of to drain or not drain, because one of the simplest ways to put plasma-rich platelets into your wound is not drain it. And many of us would drain a big hernia repair. So have you guys discussed this or have a...
So we have. We're currently designing our own clinical trial as it applies to use of PRP with synthetic mesh at our hospital. And a lot of the data actually shows that platelet-rich plasma, the effect is, a lot of it is a burst effect in the first hour. It does depend how you activate your PRP. And depending on those activation modalities, it can release up to 7 days. But a lot of it really is in the early time point, the 24 to 48 hours. So say you did have a drain in place, and that would obviously hinder your ability to release the product locally at the site where it's having effect. But we actually saw, because you brought up the idea of drains and seromas, we didn't see a significant difference between our 2 groups with seromas, and none of them got infected either. But it's a great point, because it may limit the ability of the PRP to act. Now, we soaked our mesh in the PRP. Even if you do drain, I don't know if that will have an effect, but it's definitely a talking point as we design our clinical trial.
So a couple questions, I guess. One would be kind of in your model, and I think, the translation of kind of rodent model data to meaningful clinical outcomes, I think is tough. And it sounds like you guys have already kind of started thinking about doing a clinical trial, which I applaud you on. But when I kind of look at your model, some of the outcomes in the non-treated group kind of stick out as almost like strikingly poor for if you look at other models as far as seeing recurrences at 6 months in an animal model. It's very hard to get failures in animal models. So do you think that there was maybe something technical, a learning curve? Like why was there so much negative outcome in the control arm?
We were surprised as well. And without fail, we did note that the mesh failure occurred at the very center of the mesh. I don't know if it has to do with, we did have fairly large rats. And rats are quadrupeds, so they hold a lot of their weight. Their weight is, at that site with the bridging repair at the site of greatest tension. Also, we were limited with the sheer cost of Stratus as well, of having to get our numbers of rats. Our overlap with the fascial defect was 1.5 centimeters circumferentially. That's we had to limit ourselves on that. So there's a question whether there was undue tension. However, with all the rats, there wasn't a significant difference between the rats themselves with our treated and our control groups, enough to explain the difference in our no recurrence in one arm and 75% in the other. So we're still kind of trying to dig through the data. I think a lot of it had to do with an inflammatory response, and we're trying to get down to the pure mechanism of how PRP might direct the immune response more towards a regenerative response as than to a chronic infiltrate.
So let me ask you kind of 2 other questions if we have nobody else comes up. So I think number 1 is, when I just looked at your pictures grossly of the mesh at 6 months, I was like, that doesn't look so great. It almost looks like a piece of Gore-Tex mesh. And then, I mean, on both groups. So often with these materials, you can have a kind of mesh tissue interface where you have a peritoneal lining or fibrous capsule, which could easily be assessed for vascularity, cellular ingrowth. Is the data that you showed actually within the mesh material or kind of peri-mesh is my first question. My second question is, if I'm all in and I want to do this tomorrow, what do I ask for in the OR?
So for your great questions. So your first question, for the molecular studies, the mesh itself was isolated from, as much as possible, from the overlying muscle to avoid from inadvertent false positive results. So that was the mesh itself. And as far as staining goes, we're still working through actually some of the specified staining to help delineate, like for example, the alpha smooth muscle actin. The molecular evidence is striking, but we would like to also have the correlate, histology to prove that. So we felt good about that just being the mesh versus mesh as far as molecular studies go. As far as if you want to do this tomorrow, there are several commercially available companies that currently exist. We have one that our hospital works with because it's a lot of the orthopedic and plastic surgeons who currently use it, but they will do all the legwork for you. Essentially, you draw a couple extra vials of blood. It's usually 2 extra vials. They isolate the PRP from the whole blood, which is just a double centrifugation process, and they deliver it back to you sterilely in the operating room to deliver. It's really dummy proof, which is a good thing.
I have to admit I use this in patients. I don't like to admit it, but I use it in cirrhotics when I do their umbilical hernias, and knock on wood, I haven't had a seroma since I started doing it. But if you just call your perfusionist and tell them you want, patient-derived platelet-rich plasma, they have an Angel machine or whatever it is, and they'll come in and they'll do something at the beginning of the case and hand you the vials, and it's pretty simple.
Is it like you might not know, but I'm just today. But what is the cost of this? Is this like in the hundreds?
I purposely haven't looked at the cost. So.
Does a robot have to deliver it for me? All right. Thanks very much.
Thank you.